what is the benefit of waiting for the hospital to be clean versus the risk of waiting for my cancer surgery and the cancer spreading? So essentially, when we see patients with a cancer under ordinary circumstances, we will want to get them into some kind of clinical plan as quickly as possible. Some patients need chemotherapy first, some patients need radiation first, and some patients need to go straight to surgery. When it is determined by our multidisciplinary medical teams that a patient needs an operation, we usually can get them onto the schedule within 2 weeks. Usually the delay is in some form of medical clearance, making sure their heart and lungs are appropriate and they're in as healthful a condition as possible. But the expectation is that within 2 weeks, you will be ready to have your cancer surgery. Imagine now me having to tell you as my patient that you will have to wait for an indeterminate amount of time because we have no idea when the surge is going to pass. And we usually allay patients' frustrations or concerns about the spread of a cancer, or what we call stage migration, going from stage 1 to stage 2 or stage 2 to stage 3, being something which is essentially a slow process. And although different cancers behave differently, we usually have a 6-week window in which we can do something that will not change the outcome of the disease. So as long as we were in a situation with patients who we had scheduled, we felt the clock was ticking and we had to do something within 6 weeks, and obviously shorter if possible. So I had patients who were desperate to have their cancer removed, and they would be calling me honestly weekly so that we would be able to give them an update as to what the condition in the hospital was like and when we would predict that they would first be eligible to come in. So combining their concern with our commitment to the patients, we had to not only be treating the overwhelming number of COVID-19 patients, but preparing the environment to allow us to operate on those patients who needed surgery in a safer way as possible. And so from the very beginning of the surge, we were figuring out how to create what we called NCCs, or non-COVID care environments. And that amounted to screening all personnel coming into the hospital, screening everybody who would be taking care of a particular patient during their hospitalization, ensuring that the surfaces that they were being exposed to were going to be super clean, and minimizing the amount of people and locations that a patient had to go through once coming into the hospital. So if we looked at what an ordinary admission would be like for a person coming into the hospital for an operation, imagine that on the morning of surgery, they get met in the lobby of the hospital by a chaperone. They get brought to the registration department. After registration, they get brought to the pre-surgical area. From the pre-surgical area, they get brought into the operating room, and so forth. And what we had to do is try and minimize the number of encounters so that a patient would come into the hospital and have the minimum exposure to anything that could increase their risk of getting COVID. So we have spent the past 3 months preparing systems that really consolidated our ability to protect patients. So our commitment to our patient is to ensure that they are in a non-COVID environment from the minute they come into the hospital, through the entrance, through their surgical procedure, to the moment of discharge when they leave to go home.